Good morning, everyone. My name is Linda Protopapis. I am the Executive Vice President of Sales for HealthRecon Connect. I'd like to welcome you to today's webinar, Infectious Disease, Novitas and FirstCoast Update. I hope everyone is having a great day. To walk us through this webinar and with all the changes, it is my honor to introduce you to our Director of Laboratory Services Support at HealthRecon, Mr. William Baus. William has over 15 years experience in healthcare revenue cycle management. His last decade has been entirely focused on laboratory revenue cycle, building offshore, onshore, and hybrid teams to satisfy the needs of his client. William has worked inside laboratories as the internal revenue cycle director, with preview over every step of the revenue cycle process, as well as managing RCM vendors. William is tirelessly focused on compliantly maximizing the revenue for laboratories, whether that is through adoption of technology, application of deep state knowledge of payer and national coding policies, or providing access to relationships that can change the bottom line for labs. A few reminders to all of our attendees. If you would like to ask a question, you may do that by sharing your questions via the chat box or raising your hand, upon which I will then be calling on you to ask your question, or we'll be reading those out loud. Following the conclusion of the webinar, take a few minutes of your time to please fill out a short survey. Let us know what you liked about the webinar, how we can improve, and what other topics you would find interesting for us to have going forward. As a reminder, the recording of the webinar will be published in our social media within a few days, and we'll also be sending you not only the template that William's going to be having here, but also a recording of the webinar. If you would like to speak with William or myself, please let us know. We can schedule some time to go over all of your questions sidebar. And with that, William, please take us.
Thank you, Linda.
You're welcome.
Well, I'm glad everybody came today. We're going to be talking about the provider education document that's been released by Novitas and FirstCoast. But first, to get you out of here, in case it doesn't really apply to you, we're going to make sure that this affects you or not. If it doesn't, then you can get out. And then we're going to talk about what is that issue, what's the impact, and what are your next steps. All right. So as always, the comments that we're going to make here are going to be generally applicable, that could be implemented incorrectly or not properly, let's say. So we're not advising you on how to code your specific panels. We're not offering legal advice. We're not offering medical advice, because I have none of those qualifications to do that. But you certainly want to take these generic concepts and understanding and work with your current billing, or you should come on over and talk to us at HealthRecon. All right. So first things first, what in the heck is this thing talking about? Well, in a nutshell, you get one CPT code per procedure, per methodology, and/or per test kit. And guess what Medicare didn't do? They said that, and then they didn't define what any of that stuff is. And we're going to talk about where this stuff lives and all about that. But that's what they're saying. One code per procedure, test kit, or methodology. All right. And then what does it apply to? Well, we are talking about infectious disease. And so it is talking about PCR, but also the immunoassay infectious disease panels as well. So that has a big implication. My thought process for this entire presentation is really orientated around the PCR methodology, the DNA RNA analysis, but it would apply to the immunoassay codes as well. And of course, this can have a massively significant impact on reimbursement, and it's not more money, it's less money. All right, so let's talk about this. Does it matter to your lab? While I'm talking about that, I'm gonna show you the map that we've got here. So does it affect your lab? Well, if your lab is in anywhere like for Palmetto here, or WPS here and here, or Noridian, or CGS, which is right here in Ohio and Kentucky, Well, then you don't need to worry about it because Moldex already did it for you and you only get one code. And, I thought I would kind of show you something very quickly about that. Let's do this one. So kind of the one code scenario, it's already built into your Moldex Max. And the only reason I'm really bringing this up is because, well, if you're in a Moldex Mac, then you really don't need to be here for the rest of this. But if you want to hear about what's going on for everybody else, fine. But so here's the thing. We've got 8 code groups. This is the infectious disease syndromic panels for infectious disease pathogens, right? So in this billing and coding article, there's an LCD too that has a lot more words and describes things in a verbal format. But the billing and coding article talks about codes and the code groups and their relationships, right? And I've already done other webinars on this. If you're really interested in the deep dive into understanding what this is and Zcodes and technical assessments and code group 1 and 6 and all that, you should have a look at those. There's actually a couple of them. But in how it's relating to what Novitas is doing. So they are wanting you to follow basically the one code rule. And that's what's already happened to everybody in a Moldex Mac, including the technical assessment and the Zcode. And just to kind of give you examples of that, we got 8 groups, group 1, well, this is respiratory pathogen panels. And so the 3.1, the 3.6, the 3.7, these are all worth $142. And so when you run a RPP panel that includes things more than these viral targets, there is a little bit of an out for you, but you get one more code, right? And that lives down in code group 8. Code group 8 are the CPT codes that are used when you're billing something that you don't have a code like 87631, 3637, or the GIP codes and all the other ones, right? So if I was going to have, let's say, a respiratory pathogen panel that is 25 viral targets and 15 bacterial targets, well, I would be able to, in direct opposition to FirstCoast and Novitas and NGS, for example, they don't think that 3.2 or 3.3 are medically necessary. They haven't given you a way to deal with that. Well, in any of the Moldex Macs, they do give you a way to deal with that. Well, first, of course, you have to have your Zcode and your technical assessment, but you would also need an additional diagnostic code. So if I'm going to do a 3 to 5 target panel, which are these kind of 3 here, I really only need a symptomatic diagnostic code. So I would go to code group 1 diagnostic codes and see what those are. But it's, the stuff, fever, cough, cold, that kind of stuff, right? But if I wanted to bill the 3.2, which is 6 to 11, or the 3.3, which is 12 to 25 targets, I would have to have an additional diagnostic code of an immunocompromised diagnostic code. So while the Moldex Macs may recognize larger infectious disease panels, they're still only going to give you one code, and you would have had to have an immunocompromised diagnostic code. And then what would I do to reflect my bacterial targets? Because none of the codes 3.1, 3.2, 3.3 are going to have anything to say about that. Well, there is somewhat of a little bit of an out, and it has nothing to do with multiple procedures, methodologies, or test kits. It's in fact down in code group 8, which I'll just kind of flash at you really quick. These are the codes for the individual infectious agents that you might detect. And what they say is, well, if you've already used something from code group 1 through 7 for the same intended use, so RPP is the same intended use, right? Then you can bill one additional of these codes down here, which would be basically, if you're doing an amplified probe, it's about $35. 87801, the $70 code isn't even in here, right? So anyways, what I'm saying is, Novitas, FirstCoast, NGS, they can emulate an LCD. And in fact, I think in the future, we'll talk about that a little bit more. I'll come back here. I think that's probably what they'll do. They don't need to use a Zcode and a technical assessment to basically achieve the same thing. Zcode and a technical assessment is whether you know how to run that test or not, and they get to decide whether or not you can run that test because they've decided whether you can or you can't based on passing the technical assessment. But you're still following words in here in diagnostic codes and whether you can use this code or not. All right, enough about that. Let's get back to the presentation. So in summary, this is not a problem for you. This new provider education document that has come out is not really a problem for you because you've got Moldex to contend with already, and they've already done it to you. You only get one code. So in Novitas or FirstCoast, they have released both of them a provider education document, which was released sometime in October 27th of last year. Whereas NGS has not, and you'll notice I have them in red, and there's a specific reason for that. While they have not delivered the provider education document, as you will see as we get into this, you will notice that we are dealing with something that is deeper, or actually a component of an LCD, or is in effect when there is no LCD. And so that's really a key element I want people to understand from what we discussed today. So let's back up a little bit and get back where we were. Okay, so FirstCoast, Novitas, NGS, I say yes, although NGS has not done the provider education. Moldex Max, no, not really, because you already got your problem there. I think an important aspect of what we're talking about is this provider education document is not an LCD. It is, in fact, just a provider outreach document that you can find very easily by typing in, it'll come up first, bill infectious disease properly. And the first two things that are going to come up is going to be Novitas and FirstCoast. I prefer looking at the FirstCoast one because they kind of format it a little bit better. It's verbatim for what the FirstCoast one says. And so this is what happened. They put this out back in October, right? So let's talk about this. There we go. Where that article comes from is something called the NCCI Policy Manual, Chapter 10, Section K. It is the basis for LCDs and billing and coding articles. It is contradictory in many instances to the AMA in terms of how to utilize codes. The way that a panel would be coded with multiple codes is exactly how the American Medical Association, who creates the CPT codes, well, in conjunction with Medicare and Blue Cross Blue Shield and some other people, but they're the ones who basically make up what those codes should be. And they told us how to use those codes. And they said, if you are testing this pathogen, use that code. And if you test another pathogen, test another code, and you stack these codes up, right? Well, that's not how Medicare wants to do it. And Medicare can decide how they want to do it. And how they want to do it is encased in the NCCI Policy Manual. So let's take a quick look at that real quick, just to kind of give you an idea of what this looks like. So you come to Medicare, it's a bunch of multiple chapters. If you're in laboratory, you should probably read this. It's, it's about, I don't know, 30 pages long or something. No, 22 pages. It's not that bad. You won't understand most of it, but it'll give you an idea for you to understand. And it's like the one thing that makes up how you should be coding your stuff. It's worth at least a cursory review of the different kinds of things, drug testing, chemistry for your blood work, molecular pathology when you're doing your NGS. That's the one that's telling you one code, right? Unless you have separate indications, and about parallel procedures. And we can talk about that. And if that's something you guys want to hear about, put that in the comments if you want to know about NGS testing. And then in particular, while it's funny that, so the Moldex program for the other, molecular diagnostic exchange, adopted states for those MACs, right? Which is molecular diagnostics, includes infectious disease, because we are doing DNA and RNA, but as far as it gets classified from like a coding perspective, you're looking at things that are outside of the human body, so they put it in microbiology. So all of these words that are here are what this thing is drawing upon, right? Okay, so I just wanted to make that clear that this already existed. The fact that they said something about it in October as an outreach program is them saying, hey, we don't think y'all know how to code this stuff properly the way we want you to. We need to tell you a little bit about that and clue you into it. So they took a few selected pages from the NCCI manual in chapter 10 in section K. As I just kind of mentioned there is no implementation date. It's already been in effect. It has been in effect since the beginning of time for these guys. Rules apply to panels with no LCD or panels with LCD. So another big thing about, I think, the article itself, a lot of people see, ooh, error 1, and then they're like multiple codes for single test. And then, even if you're a little savvy, you're going to know, okay, yeah, that's the LCD for RPP. Yeah, that's 876313637. Yeah, that's one code. Okay, yeah, that clicks. That's good. That's all I needed to know. They said bill it with one code. That's what my LCD said. So I should be doing that anyways already. So this doesn't really affect me. You could have looked at the gastro panel, which has its own LCD as well, and thought the same thing and said, no, this doesn't really bother me. And then you would have been missing the part down here that says, well, if you're testing for multiple infectious agents, they're only billed with one unit of service if one procedure, one method, or one test kit is used. They don't have Medicare does not have a way to talk about UTI. You don't either, really. I mean, when you're running around talking to your other buddy labs about UTI and you guys think you're talking about the same thing, you're probably not, at least from what are the component constituents of your UTI panel. They are not the same. You have many different things. Most of you will have like a crossover of about 5 pathogens. I mean, everybody's going to have E. coli and some candida, but whether you have the staph or not, that's the thing. Whether you've put STIs in your UTI or not, they're all different. And for that reason, and the fact that there is no LCD, what would you revert to? Well, I'll tell you this, you're going to be reverting to what is NCCI or manuals or CPT or AMA or the clinical laboratory fee schedule. These elements exist and are effective and enforceable without an LCD, and they exist like that, right? So let's see here. So when they talk about these, they bring up some codes for you to look at, and really those either I have individual pathogen codes or I have something for multiple organisms, and that's it right there. And then they're going to be talking about an out for you as well, which is right here in the actual education article. They're telling you, well, when multiple procedures, methods, or kits are used, then the units of service reported must equal the number of different procedures. And then nowhere in this article, nor anywhere in the, I was going to go back to the NCCI manual, nor anywhere in the NCCI manual. And I mean, I've looked through all of the chapters, but really, the table of contents and then the general area, they actually do have a definition for something called procedure, but it's not the procedure you need a definition for, right? So there is no definition from Medicare of procedure, methodology, or test kit. That is something that they expect a lab to know, how many methods, procedures, or test kits that are being utilized in conjunction or relationship to the processing of pathogens, right? So you might have, say, one test kit for 4 pathogens or something like that, right? That could be going on. And it's kind of interesting that that's it's not defined. It could be cause for frustration, or it could be cause for perhaps liberation from the context that nobody told you what that is. You get to define what that is, obviously in accordance with reality and what your clinical laboratory scientists are telling you you're doing, but you get to define that since they haven't defined that. And they may soon make a specific definition of that, but at the moment there isn't one. And so here what I'm trying to describe is what are the elements that make up the rules that we have to follow, right? And so you'll see in any LCD many times they'll be quoting various Social Security Title Acts and CFRs. Usually is right at the preamble or the beginning, and it'll be things like, it is not appropriate to bill Medicare for things as if they are medically necessary when they are not. And Medicare gets to tell you what is medically necessary or not. I think that's another really important concept, that medical necessity to Medicare is absolutely not what is medical necessity to a physician. A physician is willing to practice medicine read and understand things that may or may not have gone through clinical trials and then attempt to apply that to heal their patients. Conversely, a payer, such as Medicare or any payer, will look to medical necessity being a documented element that has gone through clinical trials and is peer reviewed and then has documented clinical utility. And so they want it to already have been done and work. So this is antithema to you developing brand new tests, for example, because that won't exist, right? And so it is limiting in terms of what a payer will consider worthy of paying for, because they have to see that it has already been done and been successful to want to pay for it, which is kind of a chicken and egg thing, right? I mean, how does anything new get developed? Well, they pay for it for a while until they stop paying for it when they say it's not medically necessary, which is what is happening right now. Okay, so NCCI, we already looked at clinical laboratory fee schedule, Medicare claims processing manuals, CPT codes and their definitions in the AMA. And there is a bit of a pecking order to this. I probably could have put in a couple more levels. NCCI, in the context of talking about Medicare, is going to trump AMA. And if NCCI says, I only want you to use this code and not stack codes, well, then that's what they can say, right? Whereas the AMA might actually say, yeah, we want you stacking a bunch of individual codes. Then what you'll have are LCDs and their billing and coding articles, and sometimes they're generic, right? Like molecular diagnostics LCD, which then you might have a specific LCD for, say, pharmacogenomics. And so you might have multiple LCDs that have an impact on you, and they are in order of, you know, the ones that are lower, they're the ones that take precedence over something else. Like, for example, we don't have an LCD for UTI. So I'm not going to have LCDs and billing and coding articles. What am I going to refer to? I'm going to refer to NCCI and manuals and the AMA and the CPTs. And then NCCI is going to trump the AMA, right? All right. So I think I've described that, yeah, this is a provider education document. It doesn't have an implementation date because it's not a billing and coding article. It already existed and has done so for some time. And let's make sure. Okay, yeah, we're good to go this way. All right. Yeah, and honestly, I don't know. I'm sure NCCI is older than 2015. But the last archived element of NCCI that you could go back and see what they said before then was in 2015. This education article, yeah, it came out on 10/27/22. But the fact of it being out there, if it was never put out there, what they're saying in this article was still true before the provider education article existed, right? What's the future look like? Well, the rules have been in effect. There is no implementation date. So now, and we already discussed this. Now, I guess I will point out about NGS. NGS has not sent a provider education article. And so if you're going to look at this event and interpreting it as, well, if there's a provider education article, then I should pay attention to this, I think that's an erroneous takeaway from this discussion. Because, as I pointed out, this thing already existed in the NCCI manual and it's been there for a couple of years at least. Okay, so what exactly is the issue? So Medicare has stated, we found providers are incorrectly billing multiple codes to describe a single test kit that evaluated multiple infectious agents. So they're expecting one code. What they're getting is something with a lot more than one code on it. And so they're pretty sure that something's awry here and it's not working out. And they're letting you know that they're aware of that as well, right? So Medicare also stated that when multiple procedures, methods, or kits are used to evaluate infectious agents, UTI, nail, wound, bone, ophthalmology, dermatology, whatever you want to have as a name, and including RPP and GIP, and meningoencephalitis and blood sepsis and the UGAG panels. Yeah, it's all of them, right? And so they want that we report CPT codes to be in alignment with procedure, method, or test kit. And they didn't define that. No surprise there. Okay. Now, what we're going to look at is there are multiplex procedures, and we're going to talk about that for a quick second. I tried to turn this dry, boring stuff into visuals, right? And then we're going to talk about non-multiplex procedures, and we're going to talk about that slide. And then we'll talk about non-multiplex, right? So let's look at these really quickly. Doing on time. Good. This is going to be a pretty straightforward one here. All right. So multiplex procedures, they kind of, and this is straight out of the provider education document, which is also straight out of the NCCI chapter 10, section K, 3 or 4 paragraphs down into it. So they're talking about, they give some examples when they said multiplex code, what are they talking about? So this is the GIP panels here, 3 to 5, 6 to 11, 12 to 25. Same thing here for the RPP, which you also have an LCD that sits on top of this, right? That says, yeah, they're only going to pay you for 87631, right? Not the 32 or the 33. And basically it's saying, you know, if all pathogens are run on the same multiplex platform method, one CPT, but if additional pathogens are run on a separate method from the multiplex platform, they are medically necessary, and they are medically necessary, right? This is a key element here, which, you know, their version of what's medically necessary might not be your doctor's, right? Then an additional CPT code can be reported based on the number of procedures, methods, or test kits. I highlighted it here in yellow. It exists in the provider education document and accordingly in the NCCI manual. Now, what that could mean then is a scenario like this. I tried to turn this into something visual. You know, it's not perfect, but it's the best I could figure out in the past couple of weeks. So I tried to represent that if you were doing one multiplex method or procedure for a group of pathogens, it's blue. And then let's say you were doing another multiplex method for a pathogen, perhaps, or another group of pathogens, it's a separate one. So if I'm using the same multiplex method, like let's say it's RPP, and like let's say I'm doing it all on one procedure, one multiplex procedure, put the thing in one end and it comes out the other end, and I'm doing it for all the pathogens, regardless of the fact that they're viral or bacterial or something else. Well, that would be one code. But let's say, for example, for some reason, like maybe, you know, and I'm not saying that this is appropriate for you in your position, in your situation, nor am I saying that, you know, breaking them out onto 2 separate runs from the same swab, like that's going to change anything for you. But I could envision perhaps one methodology being set up for COVID and another methodology being set up for medically reasonable and necessary additional targets. Well, if that was the case and everybody's okay with what their definitions are and there was medical necessity for doing it and it wasn't done just simply to achieve an additional code, well, then that would be 2 codes, right? I had one multiplex procedure and another. Yeah, that's all that this thing is saying right here. If it is medically reasonable and necessary to test by a different methodology for other types of microorganisms not included in the original multiplex test that might cause disease in the same anatomic region, RPP, lungs, the test may be reported separately. That's what that is saying. Okay. Let's see. I want to talk about, I guess we should talk about multiplex and let's talk about non-multiplex and then we'll go back to mixing it again. So a non-multiplex procedure is something that you didn't use multiplex for, but also I don't have a whole lot of codes for that too. So you may have a multiplex procedure for your UTI panel. Just because I don't have codes for them doesn't mean you weren't using a multiplex procedure, right? But if you had other procedures that are not multiplex, then you're talking about this 87801 type of code. And when multiple procedures, methods, or kits are used to evaluate multiple infectious agents, the units of service reported must equal the number of different procedures, methods, or kits used to perform the test. And then, I liked this quote. This is also directly out of the article. I think it really hones in on the point. What they're saying here in this paragraph is, okay, if I was testing for 5 different things and I used a single multiple result test kit, I would only get to bill 1 code. But if I was testing for 3 different things and I had 3 different single result test kits, then the provider may report 3 units of service of the appropriate CPT code. Or if I had a kit that was producing 4 results, I would only be able to use 1 code for that kit that did the 4 results. So, that's what they're saying here. So let me go back to kind of explaining how that would now work with a multiplex and non-multiplex. So same thing as before, if I had 3 blue triangles, it would be 1 code. If I had a separate multiplex procedure, 2 codes, like we had just said. But then let's say I had, maybe an RPP, maybe a COVID, and maybe, another test kit for some other bacterial targets. Well, then maybe that would be 3 codes. And again, you really need to look at what you're doing, come up with your definitions of procedures, methods, or test kits, and you need to evaluate that against your pathogen list and figure out what how that's going to work out for you from a coding perspective. And then if it was just a whole bunch of non-multiplex tests, it's going to be, I put the word kit in, but per kit, method, or procedure, kit 1 plus kit 2, that's 2 codes. 1, 2, 3, 3 codes. 1, 2, 3, 4, 4 codes, right? That is what is being said here, right? When multiple procedures, methods, or kits are used to evaluate multiple infectious agents, the units of service must equal the number of different procedures. So anyways, it's going to be a little bit shorter today. I mean, this is just the explanation of what that document is saying. You do want to work with your billing and coding team. I do think I spent a lot of time saying, I think you need to pay attention to it. I don't think this is something you can just bury your head in the sand and go, well, until there's a billing and coding article, it doesn't apply to me. I think I've pretty much made my point that this stuff is applicable in the absence of an LCD. It is the basis for LCDs, right? So what should your next steps be? You should identify the relationship of your pathogens to your test kits, procedures, and methodologies, and get clear with yourselves on what those relationships are. And then, you work with your biller to understand the impact of the changes to your billing. And then, as always, of course, you can't just take what has been said here and just directly go off and apply it. We have not looked or discussed your exact panels and your methods and your procedures and your test kits, and all of the things that go into that. You wouldn't want to just blindly rely on the information you gathered here today to come up with your own conclusion on it without support of appropriately certified and qualified professionals, which are going to be 2 levels. You're going to need to be able to talk to the type of people who set up and validate and created your methods for your instrumentation. And you're also going to need to talk to somebody who's familiar with that billing and coding policy. In the NCCI chapter manual, NCPT codes. Yeah. And those 2 people together would be able to figure this out for you. Which we would love to be. We'd love to be a big component of that for you. And then, of course, you can always contact us, and we'd be happy to help you. So that concludes what I'm here to say. Do we have questions? Wow, this is the biggest one we've ever had. This is a lot of people here today.
Mm-hmm. Any questions for William? And also just to let everyone know that HealthRecon can also offer a coding analysis, just to make sure that you're coding correctly. We would be more than glad to assist on that. Any questions for William?
Everybody got off easy then.
Yeah. So just as a reminder, this brings us to a close of today's webinar. Again, the recording will be on our social media page in just a few days, and we'll also send out this template for you and also the recording. And I think, William, we do have one Q&A. If you can.
The Q&A. Oh, okay. Yeah. Q&A. Where are they? I see. There it is. Is 87631 used to report virus or for bacteria too? So 87631 itself is 3 to 5 viral targets. But let me back up on a slide and give you the, you know what? I'll just show it to you in the document. Well, infectious. So what part of the document do I want to show you? Okay. Well, independent culture. Okay. So first you'd have to know that we were talking about multiplex codes. 87631 is one of those. Okay, great. So if you're using one of these multiplex tests, which that's what you're asking for, and an additional testing by these methods for additional microorganisms that might cause disease in the anatomic region described by the code descriptor is performed, only one multiplex testing code summing the testing for all targets shall be reported. So they don't care that 87631 says only viral and that you've got bacterial targets. If you are using the same procedure, method, or test kit as you are for the RPP, then you will only report one code. But if you are using a different methodology, and in this case, they're very specific between the multiplex that they're talking about a different methodology. But if it is medically reasonable and necessary to test different methodology for different microorganisms not included in the multiplex test that might cause disease in that anatomic region, lungs, the test may be reported separately. Now, I will tell you this. It's very clear in the LCD that you have in Novitas and FirstCoast and NGS, by the way. They find no value in testing otherwise immunocompetent, and they find no value in testing immunocompetent patients. So somebody who does not have HIV, a transplant, surgery, cancer, or other drugs, or genetic immunodeficiencies, then you are immunocompetent. And the standard of care dictates that they're going to give you a Z-Pack, and they're going to find out if you've got a viral target. And then only if there is found to be COVID or flu do they even have a change in treatment. And so they're looking at the clinical utility of this and saying, better be medically necessary that you are testing some additional pathogens by an additional method. Okay. Okay, so somebody asked me if 87798 is non-multiplex. If the code itself is only defining that it's an not otherwise specified pathogen, so it could be used in a multiplex concept, and it could also be used in a non-multiplex concept. It might not be the best choice for you because it's worth $35. And the 87801 is effectively the same thing as an 87798 in that it's not otherwise specified, but it's multiple organisms. And so 87798 is for an individual organism. So yeah, you can bill it to get paid. And so the thing to be clear about is this has already been in effect and it's been there. So you are already getting paid for it, and there's been no change to what the rules are, which is probably confusing as all get out to a lot of people. And what that would be is Medicare considers themselves to be a good faith payer. What that means in their minds is that they've provided enough information for us to be aware of what we're supposed to bill to them. Yet, there are only 33 fields in a claim form. The 33 fields in that claim form do not provide Medicare with the information on, for example, procedures, methods, or test kits. They are unable to evaluate if you are in adherence with their expectations until they audit you. So they're probably going to continue to pay people that are obviously out of compliance with this, because they can't tell if you're out of compliance until they audit you and ask you a bunch of questions. I could think that they could bet that they're only expecting this to happen in rare instances, and anytime they're seeing more than one code go down, or somebody say doing 20 codes versus somebody doing 3 codes, they're probably going to be looking at the people that are doing an obviously unreconcilable amount of different procedures, methods, and test kits. Can you use 87801 with 87631 in a MolDX MAC? Okay, in a MolDX MAC, none of anything of what I said matters, right? The MolDX MACs do not care about separate procedures, methods, or test kits. You need a technical assessment and a Zcode. And at the successful completion of that, and by the way, I did a very nice webinar on the whole MolDX Zcode thing and explains that in a lot of detail. But until you get your technical assessment approved and you have not only a Zcode, just getting a Zcode means nothing. They give you a Zcode, then they ask you to do your technical assessment. Until your technical assessment is complete, you will not have a covered a covered Zcode. And until then, you won't, well, you might be able to get paid because people had done that. And that is people are starting to get denials now. And I would also be suspicious that there'll be clawbacks on the heels of that as well for anybody who continued to bill without a technical assessment and a Zcode approved to Medicare in the MolDX MACs after month 5 and 6 for the respective MACs. They kind of implemented on a little different time frame. And no, the answer is 87801 and 87631 are not going to be used to describe the same panel. You could use something from code group 1, which would be 87631, and then something from code group 8, and 87801 is not part of code group 8, or at least 2 months ago it wasn't. I haven't looked at it recently. Anonymous attendee, if it is an FDA approved and only 5 targets, do you need a Zcode? Yes. The syndromic, okay, so the question is, and I find this to be something that a lot of folks might be slightly confused about, and I'll explain to you why I think that is that way here right now. So the question is, if I'm doing 5 pathogens or less, do I really need a Zcode? And also mixed in with the FDA question. So first things first, we need to go to the LCD here. And we scroll down here, and this is what people, I think, got kind of confused about. This whole syndromic panel LCD is for anything that's 2 or more pathogens. So if you were doing COVID only, even though I might use 2 different CPT codes to describe it, it is a single pathogen test. Single pathogen tests are not covered under this document. Also, nor is Part A. Anybody in a Part A stay doesn't have to apply to this, right? But in the context of whether or not you have a panel that's covered, as long as you're doing 2 or more pathogens, everything in this LCD applies. And therefore, services that do not have an FDA cleared and approved and indicated uses, as well as an FDA approved test performed in ways not consistent with their intended use labeling and instructions. If you're not doing it exactly the way the IFU said, you do need to have a MolDX program. And in addition to this, it can only be 1 test. If you try to take 2 FDA tests and stack them together to make a test, then you are not using it in ways consistent and intended for use by the FDA approval. But if somehow, by some miracle, you are able to get, a test that doesn't cost you $120, for which you will only be paid $142 for, and it was FDA approved, and you did just 1 test, then you wouldn't need a Zcode and a technical assessment. Now, the thing about this 5 pathogens or more or less, I think the thing that people kind of got confused about is they saw this as if they thought this this only applied for greater than 5 pathogens. And that's just because you're not reading the LCD properly. It says it multiple times throughout the document because it's referencing that it's different for 5 pathogens and less, and there's a completely different set of instructions for anything greater than 5. And that's what this thing is saying here. These are all different bullet points under the general criteria. These are general criteria bullet points until you get down to non-coverage criteria, and then you get to limited coverage. And in these bullet points, they're talking about, hey, make sure you look at if you're talking about something bigger than 5 pathogens. And truly, the only tests that are even related to this are your RPP and your GIP. So there's that. I think that's it. FDA, thank you. You're welcome. Can you say that? How about no? That's it. I think that's it. So really much appreciate you guys coming. Fantastic turnout. Let us know if there's other topics you want to hear about. I'm thinking about doing something on NGS. I'm thinking about doing something about what does the end of the pandemic mean? And we're also looking at a 5-part mini series on how technology can help you increase your revenue bottom line. But if you come up with anything else, we would love to hear about it, and I would love to make it for you.
Thank you, William. And again, if you have any questions whatsoever, we'll be sending out an email. Please feel free to respond to that so we can follow back up with you. And if Ravi is on the call, I will follow back up with you, Ravi. Thank you so much, everyone, and have a great day. Thanks, William.